Dr. Weaver, you can start.
Okay. Hello, everyone. Welcome to Spine Time. My name is Joshua Weaver. I'm a neurologist and one of the co-directors of the Center for Comprehensive Spine Care at Weill Cornell. My great pleasure, together with my co-directors and the staff here at the Spine Center, to welcome you to the latest installment of our Spine Time webinar. Today, we're covering a really important topic: sprains and spasms, pulls and tears. The reason I find it so important to discuss is that neck and back pain and arm and leg pain are just so incredibly common. And as a neurologist, I often see patients with nerve-related pain, but very, very often, more often than not, there's a lot of pain that's being generated by other types of tissue, by soft tissue, including muscles, tendons, ligaments. And I'm really happy that we have our speakers here today to go into this in more detail because they really are experts in this area. I'm just going to click to the next slide here. So I just wanted to thank not only the speakers today, but our co-directors and the staff at the Spine Center. Also really want to thank and highlight the tremendous amount of work the team behind the scenes that puts these webinars together every 2 weeks. So Roseanne, Tatiana, the team at the Neurosurgery Group at Cornell. We really appreciate all your efforts. As you may know, we work at 59th and 2nd at the Weill Cornell Medicine Center for Comprehensive Spine Care. We have over 20 physicians on staff. We work with rehabilitation medicine, sports medicine, pain management, neurology, neurosurgery, but we also really work closely with other medical disciplines as well, including complementary medicine doctors and practitioners, nutritionists, psychologists, physical therapists, all at Weill Cornell or in the community. And we really try to take comprehensive care of our patients. So before we start with our speakers, I just wanted to say a few words about the webinar. So these webinars are being recorded. We just wanted to remind you to turn your videos off, although I think that's the default for everyone coming in. I really want to highlight that during the course of the webinar, there is a chat function for this. And so really what we love when we're doing these webinars is to be able to answer questions that you may have, and this is an opportunity for you to do so. So I will be monitoring the chat and we'll try to get to as many questions as we can. So without further ado, I just want to introduce our speakers today. So today we have Dr. Tiffany Lin, who is an assistant attending anesthesiologist and instructor in anesthesiology, who also specializes in pain medicine. And then we have Dr. Vincent Miccio, who is an assistant attending physician and assistant professor of clinical rehabilitation medicine. And both of them are really experts in this field, particularly in soft tissue, but all sorts of different kinds of pain. So I think the first slide we're up with Dr. Lin. I'm gonna pass this on to you. So why don't you go ahead and take it away.
Hi, everyone. So first, soft tissue that encompasses muscles, ligaments, and tendons, as Dr. Weaver talked about. And it is one of the most common complaints that we see in the primary care physician's office or at our pain management practice. And a lot of times it can be difficult to diagnose because soft tissue pain can be very broad, very non-specific. There's no particular imaging that's kind of gold standard for diagnosing soft tissue pain. And that's why I think a lot of people can have a lot of frustration trying to figure out exactly where the pain is coming from. But generally, there's many causes of soft tissue pain. It could be from a traumatic injury where you have a tear in your muscle or tendon. It could be from excessive strain or sprain, so like a basketball player who uses his shoulder all the time. It could be from repetitive motions. If you have a job entails you reaching up all the time, that could also cause soft tissue pain. Abnormal tension could be from body asymmetry. If someone has leg discrepancy on both sides, they can develop back pain, muscle strain because of that. Poor posture, which we see a lot in our civilized world because of our use of computers, cell phones. A lot of times we find ourselves in a crouch position, head protruding forward. That can cause a lot of strain in your back and neck muscles. And also lack of activity. If someone has a broken arm, that's kept in a sling for weeks, obviously you can have muscle weakness and soreness develop from that. So what do you experience when you have soft tissue pain? So you can have tenderness. A lot of people describe it as soreness, muscle spasm. You can have movement dysfunction from that, where, you know, it could be painful for you to be turning your neck. You feel like your neck is stuck. And a lot of patients also describe trigger points, which can be, which, you know, a lot of people call it knots in your muscles, which are taut band of muscles. They can be painful when you compress it. Sometimes it'll elicit a twitch response when you press on it. And when you do press on it, sometimes it can cause referred pain to different locations. And each muscle sometimes has predictable pattern of referred pain. When we look at these trigger points, you know, neurophysiologically, we see that the muscles have spontaneous electrical activity. They are usually located near neuromuscular junctions, and they can have higher concentration of inflammatory markers in the area. And the theory behind that is when you have a very tight muscle, it constricts a blood vessel that supplies the area and can cause local ischemia, which causes inflammatory reaction. Next slide.
Really great, Dr. Lin. Before we move on to the next slide, well, first I just wanted to say that it's like, I'm so guilty of this, the postural issues. I tell people all the time, I tell all my patients, and then I take the subway to work and I'm literally like this on my phone for like 45 minutes.
I'm the same way.
I'm like, oh, I feel it in my neck and I know better, but I still do it. Maybe I just want to throw it out there because, you know, I see a lot of patients, we all do here at the Spine Center, with back and neck pain, you know, who have pain and tenderness and movement dysfunction and could even have trigger points. But how do you tell, you know, what's nerve, what's disc, what's muscle? I don't know, Dr. Miccio, if you want to weigh in on that, and then we can go back to the slides really quick after that.
First off, I think that was a great summary of what soft tissue pain feels like, what it can be caused by. And I think that, you know, somewhat mistakenly, we assume that soft tissue injury, as in muscle injury and such, is a simple thing. But actually, it's quite complicated because it looks just like so many other things that, and I joke with my patients sometimes that this is what keeps me gainfully employed, is that muscle pain can look like disc pain. Muscle pain can look like pain from a joint in the back and such, and that is compounded by the fact that because of most of our lifestyles are experienced in front of a computer or using a phone, you know, all of those elements are constantly stressed, and it can be difficult to tease out what is disc, what is joint, what is muscle sometimes. Dr. Lin, what you have highlighted here is very important. I tend to find that my physical exam really helps me tease out what is muscular pain versus other types of pain. And it's that tenderness that really makes the difference. So if you can really elicit a patient's discomfort by pushing on those muscles, and the patient says, yes, that's the spot, then you know you're onto something. Whereas, you know, to be fair, a lot of the more deeper structures of the body, like discs, for instance, and to a certain extent, joints, are a little bit more difficult to, it's more difficult to elicit pain just by palpating on the area. Another thing I want to mention is that, you know, Dr. Lin mentioned about repetitive motions and such. And often, you know, I describe to my patients that this act of kind of sitting at a desk and working all day is essentially a repetitive stress injury that you can get in your soft tissue. And, you know, for instance, if you're hunched over looking at your phone, essentially those muscles that are stabilizing the neck are just working overtime. They're chronically tonic, you know, they're chronically contracted, and that can definitely lead to protracted muscular pain.
Got it. Dr. Lin, anything you wanted to add on that?
Yeah, definitely, I agree. A lot of times it can be difficult to tease out whether the pain is coming from a nerve, joints, or muscles. And honestly, a lot of times, you know, a patient could have all of them. So a patient could have cervical radiculopathy that causes shooting pain down the arm. But at the same time, when you have nerve pain, you know, you're, you know, subconsciously holding a weird posture, and that can cause, you know, shoulder pain, muscle pain. So a lot of times when I see these patients, they have what I call multifactorial pain because they have pain coming from every single system. So a lot of times I tell patients, you know, each system requires different kind of treatment. So we kind of have to go through one by one because they are interconnected. You know, you're not just made up of nerves, you're not just made up of bones. It's we're made of nerves, bones, and muscles. So a lot of times one can affect the other, and we have to treat all of them.
Love that. And actually, so speaking of treatment, we're going to get into a lot of different types of treatments that are out there. And Dr. Lin and Dr. Miccio are going to kind of talk about various topics in there. I just wanted to remind everyone the chat box is open. Please put in questions, and we'll be getting to them as soon as we're done running through the slides.
You know, I think that certainly physical exam informs us a lot about whether somebody has active musculoskeletal pain. But one tool that I use in my practice is musculoskeletal ultrasound. And when we talk about, you know, soft tissue injuries or muscle injuries that can cause back pain, one of the muscles that can be a culprit is the piriformis muscle. And that is depicted here in the upper left-hand corner. It is a muscle that connects the sacrum to the femur, specifically to this bony area here called the greater trochanter. And what we can use is using an ultrasound machine pictured in the lower left-hand corner here. You can actually visualize these muscles. And if you look from side to side, from a unaffected side here on the right to the affected side here on the left, you can sometimes see enlargement of the muscles. And you can also see changes in the architecture of the muscles. And in the lower right-hand corner, this is actually a piriformis injection that I did where the needle is that sort of bright white line going into the muscle. And so that ultrasound is a tool that we can use to further assess things. I have to say, you know, specifically soft tissue injury of the back, it's a little bit more difficult to assess that with ultrasound, but ultrasound in general for soft tissue injuries is a common tool that we use, and it can help inform our physical exam. It's almost like an extension of our physical exam. So I wanted to talk a little bit, you know, as we transition into therapeutic options for soft tissue injury. The first thing that comes to mind is therapeutic exercise and physical therapy, especially when it comes to soft tissue injury of the back. The main tool that we have is core strengthening. And we hear that term a lot. We hear strengthening the core. We hear that strengthening the core is important quite a bit. But first of all, we have to talk about what is the core, right? So here, the core is made up of muscles of the back, muscles of the abdomen, and even muscles of the pelvic floor. The muscles of the back that contribute to your core are many. Some of the most important players are the deep paraspinal muscles, especially the multifidi, which are these muscles that attach one spinal segment to the next, and they help stabilize the spine and help provide feedback for kind of where our spine is in space. Another really important muscle group are these group of three muscles called the erector spinae. The erector spinae are these kind of almost like cord-like muscles that run the length of the spine. There's one on one side, one on the other side, and they help us extend our back backwards and help stabilize our back. In the abdomen, obviously there are our abdominal muscles, the rectus abdominis, but there are also these muscles that sort of form a band-like corset around the core, known as the internal and the external obliques and the transversus abdominis. Those are very big players in terms of the core itself. Next slide, please. You know, a extensive overview of the different exercises that one can do to strengthen the core is way beyond the scope of this presentation. However, I wanted to highlight the big three. The big three here are at the top of the screen, curl-ups or crunches, and we have side planks, and then we have a bird dog exercise that's on the right-hand side here. One thing I want to note is that not all core exercises are created equal. And so, you know, 20 years ago, people were encouraging people to do sit-ups, but those have fallen out of vogue because sit-ups involve recruiting your psoas muscles, which is a hip flexor. And what that does is it puts stress on your spinal segments and ends up shearing some of the spinal segments. So instead, we recommend doing crunches to work the abdominal muscles without shearing these spinal segments. And if you hear my dog in the background, I apologize to everybody listening. Side planks. Side planks are a great way of stabilizing the transversus abdominis and the internal and external obliques. This has been proven with scientific studies where they looked at electrical activity of these muscles. And the bird dogs are great ways to strengthen the erector spinae. You can see here, starting at the top, this is the easiest version, medium, and then advanced at the bottom there. I should have probably called this the big four and just added in some good old planks here. But this sort of gets the point across, is that basically what we're trying to do is strengthen the core without engaging the hip flexors in order to reduce shear forces on the discs of the lumbar spine. When we have a soft tissue injury and we get a massage or something like that, it feels good. We all know this. We've all experienced this. However, one thing to note is that unfortunately, there is not robust scientific data to support the use of these manual therapies that you see here on the left-hand side here. There are a variety of different techniques that are used. And I will say that for anybody who is a physical therapy practitioner and sees a patient with a soft tissue injury, these therapies are generally included in the protocol for treating it. However, there is a lot more study that needs to be involved. And I will say that designing studies to examine the efficaciousness of these things is incredibly difficult. And just because we do not have evidence that this stuff works doesn't mean it doesn't work. It means that it has not been examined enough to really prove that it is truly efficacious. So there are a lot of different therapies out there. I would say that it is hard to put, extreme weight on any one of them, but it's usually part of a protocol, of a physical therapy protocol.
So next I'll talk about the trigger point injection. So like I talked about earlier, trigger points are where you have top bands of muscles that cut off circulation to the local area. And so basically what a trigger point injection does is we insert needle into the muscle where the tight bands are, and we basically do repeated dry needling to basically cause structural damage and loosen up the trigger point itself. A lot of times practitioners would inject local anesthetics like a lidocaine just for patients' comfort, but the numbing medication itself doesn't have long-term benefit. It just makes the procedure more tolerable. The benefit of the trigger point injection is in the dry needling itself, where you break up the trigger point, you break up the knots, bring in blood flow to the area, and kind of wash away the inflammatory markers that have built up in the area. So in the picture, you can see generally what I find from ultrasound when I do trigger point injection is an affected muscle would generally look more dark than normal. And that correlates to the theory that there's less blood flow to the area because blood and water, they are, if you have fluid in there, it's gonna turn up more brighter. So, and after I do the trigger point injection, I generally see that the muscle becomes wider, which proves that there is more blood flow to the area. This is just anecdotally. I don't know if that's what people generally see on ultrasound, but that's just something that I've noticed. And aside from trigger point injection, sometimes we will also inject Botox into the area. If trigger point injection doesn't last long enough, patient wants longer term relief, Botox usually gives you relief for up to 3 months. Next slide. So acupuncture, a lot of patients have asked me about, whether acupuncture could be helpful in their soft tissue pain. And I don't personally perform it, but it has been used in traditional Chinese medicine for over 2,000 years, not just for soft tissue pain, but for a variety of illnesses. And basically a theory behind that is the meridian theory. So your body has 12 meridians, and along them, there are 365 acupoints. And these acupoints from anatomy, research, they found that they're usually found in natural clefts of the body between muscles. They are often hypersensitive to palpation. And when they look at these acupoints, they actually find that there's higher density of nerve fibers in these acupoints, and they actually correlate to cutaneous branches of major nerves. So there is an anatomical correlation with their nerve bundles with these acupoints. And there are many ways that acupuncture can be done. It can be done by needle itself, which sometimes they will apply heat or electricity to it. Sometimes it could just be a manual acupressure, either by hand or by these little beads. And they have done studies to look at, how acupuncture works. And generally they found that it can cause an anti-inflammatory effect. It can suppress your peripheral nerve receptors from transmitting noxious stimuli input into your brain. So overall, I generally do, encourage patients to pursue acupuncture. It's minimally invasive, and there's not significant side effects or complications that you can get from acupuncture. So I think this is a good, alternative as well. And another technology that we offer at our pain clinic is high power laser therapy. So this is basically a non-ionizing light source that it comes out of a probe. This is different from the laser therapy that you typically see at a physical therapist's office. At a PT office, you generally see a low-level laser therapy that only gives off 0.5 watts. The high-power laser therapy can go up to 40 watts. So basically what it does is it delivers more energy and is able to penetrate deeper into the muscular structures at a lesser amount of time. And how it works is that basically it also addresses the energy crisis model of soft tissue pain. When it delivers energy into the soft tissue, and can increase energy production and metabolism of the cells. It also decreases inflammation, and it can help recruit blood flow to the area to accelerate healing. And we currently offer that in our office, and we have seen promising results.
Those are all great therapies. I actually refer some of my patients to Dr. Lin's team to do some of that laser therapy, especially in folks who I think have musculoskeletal, muscular pain, but we're sort of at a bit of an impasse. And are looking for ways to move forward. One comment that I would have about acupuncture is I also use acupuncture in my practice quite a bit. I don't do it personally, but I refer out for it. Is that acupuncture is kind of infinitely customizable, which is really quite nice. There are an endless amount of different configuration of needles and such to address whatever needs the patient has at that time. One thing I would say is that, generally it takes about 5 to 6 treatments for you to really know if the acupuncture is working. So I really encourage my patients to, don't show up for one visit and then give up on it. You got to give it a little bit of time to work. But I also refer patients for acupuncture quite often. And another treatment that we have in our toolbox here is PRP, platelet-rich plasma, which we could do a 5-hour talk on, but I'll give you a brief overview here. So platelet-rich plasma, what it is it is a product created from your own blood. It involves drawing your blood, spinning it in a centrifuge to concentrate the platelets. Those platelets contain growth factors. And then you inject those growth factors either into a tendon or a joint, or in some cases into a painful muscle in order to stimulate healing. it is essentially a concentrated dose of platelets. And this has been used as far back as 1987 to stimulate wound healing in cardiac cases. And it has a variety of uses. It is used from, in cosmetic surgeries to dental surgeries and all of that. In our cases, if we go to the next slide, I can show you some of the applications that we use it for. In the back, we most commonly use it for facet joints, which are some joints in the lower back that can cause discomfort. We often use it for the sacroiliac joint as well. These are not soft tissue injuries, but these are kind of joints that are in the back that we use it for. We less commonly use it for soft tissue injuries, and I will say there's less data for that, but that data is growing. And it can be an option for people who we suspect there is muscular pain, and we're looking for any way we can to help people feel a bit better. Good. The next therapy that I would like to talk about is probably the most experimental. It's called extracorporeal shockwave therapy. And this is actually a therapy that has been around for some time and is used quite commonly in Europe, but not really so much in the US. It's just starting to catch on in the US. And it works in a similar way to the laser. Essentially, it's delivering energy into the tissue. And there's a variety of different ways to provide that energy, depending on what type of device you have. It is most commonly used in the United States for things like plantar fasciitis or tennis elbow. And there's a decent amount of data to show that that works. There is a bit less data to show that it works for soft tissue injuries, but I have some patients that I've referred to some of my colleagues who do this. I don't do it myself, to help them with these soft tissue injuries that seem refractory to basic treatments. A good example for that is, as Dr. Lin mentioned earlier, often you will have a primary pathology that is present and you'll have muscle spasming around that area. So for instance, I have a very young fellow who had a spinal fusion, and the discomfort that he had from the spinal fusion largely resolved, but he was left with this sort of tightness and this pain with palpation of the muscular structures of his lower back. And so right now we're experimenting with having him go through a course of extracorporeal shockwave therapy in order to try and treat that. So those are some of the tools that I use in my clinic.
That's great. Thank you so much, Drs. Lin and Miccio. I think we really got a lot of very interesting viewpoints here and a lot of different treatments that are available. I didn't even realize all these things were available as a neurologist. We don't usually foray into all these different gadgets. As I said, we were setting up. I was like, wow, you guys have a lot of fun tools that you work with here. We have a few questions that have come through, and I wanted to get to those. I think it's interesting about the injections because trigger point injections, because I actually for a long time never realized that it doesn't necessarily mean you're actually injecting, something into the muscle. It's actually more about the needling and sort of breaking up the muscle, which is actually kind of interesting. Someone had asked here, about trigger point injections. I think there's a lot of confusion because we call all these things injections, but what are we really doing? So someone said, is a trigger point injection the same thing as a hip injection for bursitis? What are you doing in those cases? What are you injecting there? What's the difference?
So trigger point injection is different from a bursa injection. So there's a bursa, it's called a greater trochanteric bursa, that's on the outside of the hip. And sometimes that bursa, it's a potential space for fluid. And sometimes it can be irritated, inflamed, and have a buildup of fluid in the bursa itself that causes pain. So when someone does a hip injection for bursitis, they inject numbing medication and steroid into that collection of fluid. So it's different from trigger point injection, where trigger point injection goes directly into the muscle itself.
Great. Another thing I thought was interesting was the acupuncture. I also send a lot of patients, to acupuncture, or at least offer it as an option. And I think Dr. Miccio, your point about it being infinitely customizable is really interesting because, I think that also calls into the fact that a lot of procedures that we do are very user dependent. It depends on who you go to, depends on how much experience they have, how skilled they are. And I think sometimes when acupuncture fails, it could be for a number of reasons. I have some patients who love it. They come back and they're like, wow, it really changed things for me. I feel so much better. And some people who really didn't feel like it made much of a difference. And it could be that they're going to someone who may be less experienced. I think it's important to find people who are properly licensed in it, who know, really what they're doing and their experience. It also could be, like you mentioned, maybe they only did 1 or 2 sessions, and it might take a while for that to really kick in. And I do want to highlight that although it is low risk, it's not no risk. And I usually tell my patients that as well. Because there's a needle going into the skin, there's always the potential there for some amount of risk, but it is very, very low. But it is important to know going in that with any procedure, there's always some amount of risk, even if it is very low. So a couple of other things that have come up, just some other questions here. Let's see, in terms of, actually, this one's more of a logistical question, but I am kind of curious about it. Someone asked about insurance coverage for all these fancy gadgets that we have, does insurance cover these things in general? And I think specifically the question was, I have to find it here, for the PRP injections, but I'm just curious in general for all of these different treatments. Is it the case that most insurances cover or not so much?
Yeah, I mean, I guess we'll start at the top and work our way down. So, of course, physical therapy is covered, and those manual therapies that I mentioned, those are generally covered as part of physical therapy. Trigger point injections are almost always covered. Acupuncture, it depends on your insurance program. Often I am asked if I can recommend acupuncturists, and to be honest, often I pose the question back to the patient. I say, actually, you probably should contact your insurance company and see if they can provide you with a list of practitioners that are covered under your plan. That's probably the quickest way to determine who in your area is covered. But most insurance companies, I would say, to a certain extent, cover acupuncture at this point. Then we get to the laser therapy. I don't know, Dr. Lin, if you could speak about that.
Yeah, I don't believe laser therapy is covered, at least not in our clinic. Yeah.
From what I've heard, I don't think it's very expensive, and so I tend to refer pretty liberally because I think it's quite affordable, actually. And so let's see some of the other therapies. PRP is on the more expensive side of things, absolutely. So that is not covered by insurance. And I see in the chat box is that any progress that has been made on getting PRP to be covered by insurance? And the answer is no. I have not seen any progress that's made in that. In the several years that I've been doing this, I have seen exactly one insurance take PRP one time. So it's exceedingly rare for insurance companies to pay for PRP. And shockwave therapy is also not covered by insurance. It costs the same. It ends up costing about the same amount as PRP, but it is kind of spaced out over increments because most people need about 4 or 5 treatments of shockwave. So it ends up in the end being about the same as PRP. So unfortunately, it is an out-of-pocket cost.
That's good to know, and I think it's really important too. That just highlights that the need for more clinical studies. If we can really show efficacy for these and show data, then we're able to go back, to insurance companies and say, look, this really works, and try to get those things covered. But
what I will say,
the process,
if I may, is that the research on this is really fascinating because with shockwave, for instance, there are all different types of settings that you can have for how the energy is delivered, in what density the energy is delivered, how many times you're doing the treatment, et cetera, et cetera. And it's still being ongoing. It's an ongoing area of research. PRP is the same way. Not all PRP is the same as every other type of PRP. Everybody's platelets are different. Everybody has a different concentration of growth factors. And we're talking about, hundreds of growth factors that are contained within PRP. And it is incredibly difficult to parse out which are the active ingredients, which are the beneficial ingredients. And so when you have one study that touts PRP as being beneficial and one study that touts PRP as being, essentially unhelpful, unfortunately, the studies have not been standardized to a great extent such that you can compare one type of PRP to another type of PRP. And researchers are actively working on that, try and get the medical community to agree on how to standardize and how to assess what is in the PRP that we're giving people. It's harder than it sounds.
Absolutely, that's a really, really good point. And it also just highlights how much variability there is, not only with the people getting the treatments, but also what the treatments are exactly, how people are going to respond. Someone just brought up, they'd done acupuncture, really no improvement, but went to someone who was highly recommended, went a bunch of times. And I just think that's true of even just medications. You find some people who really respond to a medication and some people who really don't. And there's a lot of idiosyncrasy with this. So it's difficult, to find the right one for the right person. But that's why we try to make guided, efforts to sort of figure that out and help the patient through. So a couple of other things. Have either of you come across, you have a patient with pain and maybe it's the nerve and disc and muscle combo, you have a lot of things going on, and PT, physical therapy is part of the treatment, plan. Some people, and I've had this happen with some patients too, they come back, they either say, it really didn't work for me, or even some people feel like it made them worse, I guess, why do you think that is? And should we be, doing specific techniques for physical therapy for these types of soft tissue injuries? Or are there other types of physical therapy that are more directed or more beneficial?
I do find a lot of times patients say, they can't do physical therapy because of pain, or the physical therapy made the pain worse. Typically, if someone does, say the pain is so bad that they can't go to physical therapy, I tend to, if it's from a cervical radiculopathy, I tend to do, an epidural injection first, make sure that their pain is improved where they feel good enough to go to physical therapy. But I do tell them that, all the interventions that we do, they're all symptom relief, and the real long-term solution is physical therapy. They need to get stronger, they need to rebuild their muscles so they can support their spinal structures better with the muscle and not just relying on the bone itself, because that would just cause further degeneration. So, and all the things that we do are all just, aids for them to feel better so they can do long-term physical therapy.
I guess the one, I totally agree with that. The one thing I'd add is that it matters what you're doing in physical therapy, right? And so I think as one of the things that I seek to do as a physician when I'm evaluating a patient, especially with back pain and spine pain, is you attempt to find the patient's directional preference. For most people who have, for instance, a herniated disc, the directional preference will be one of extension, that is bending backwards. But the thing is not everybody is like that. Some people have more pain with bending backwards. And just like everybody, a lot of us rely on pattern recognition. And so if you go to a physical therapy place and you happen to be one of those folks who has pain when you're extending backward, sometimes the PT can put you, they can get blinders on, and they can use their standard protocol, which is making you bend backwards, because most people get relief when they bend backwards when they have a herniated disc. So, I think that's sort of my job as a physician, is to alert, in my physical therapy prescription, to alert the physical therapist that, hey, this patient actually has pain with extension. It's a little atypical, but that means we should build a protocol, a physical therapy protocol around keeping the spine in neutral or with some flexion. Sometimes it is the actual quality and the actual content of what you're doing in PT that matters as well.
Excellent. Thank you guys for that. So that actually also segues, and there was a question in here about, someone had said, I actually thought flexion exercises like crunches were actually unhealthy. Is that true, or is that a myth? Or is it kind of anything is unhealthy if you do it to extremes, or what are we talking about here?
Yeah, I think all of, to answer your question, I would say yes, right? So, number one, what are you flexing, right? When we talk about avoiding flexion, we're talking about flexing at the lumbosacral junction, which is that lower spinal segments. Those lower discs, the L4-5, L5-S1 disc, those are, 85, 90% of the time, those are the culprit with disc-mediated lower back pain. And yes, you want to try and avoid repetitive flexing of those segments. Doing a crunch flexes more of the thoracic region. And so it doesn't necessarily contribute to flexion of that area. The sit-ups, which I said that you should avoid, what that does is it pulls on those lower lumbar segments and it shears those lower lumbar segments. And that's why you want to avoid that. I could go on and on about that, but I'll leave it at that.
Got it. Well, we only have a couple more minutes, and I did want to bring up, a couple of people are asking, I'm so curious by these things. They almost look like science fiction, like weapons or something.
Ray guns.
Yeah, exactly, like ray guns. For shockwave therapy, for the laser therapy, are these, just logistically, for what would patients expect when they go in? And I don't know, Dr. Lin, I think you might do more of these. Are these found to be painful, like actually doing the treatments, or do people get relief, right away and they feel good, from these?
Yeah, so the laser therapy, the only thing that patients would feel is just basically warmth coming from the laser itself. Sometimes, if it gets too hot, we will take a break or lower the energy, but normally it doesn't cause any pain. We do recommend doing at least 2 or 3 treatments before deciding if it's working for you or not, because it will take time for the effect to build up. So that's why we generally recommend 5 sessions to begin with. And then after that, decide if it's helpful for you and whether to continue or not.
And I don't know if either of you do the shockwave therapy. Do you know, like, just the patient experience side of things, how it is?
The way I've heard it described is it's like an elastic band flicking on your skin.
Oh.
So not the most pleasant feeling in the world, but just like Dr. Lin was saying about the laser, you can adjust the amount of energy that is delivered to make it more or less painful. So what they do is they essentially titrate it to your level of discomfort. So they're able to adjust it.
Got it. That makes a lot of sense. All right. Well, actually, I think we should probably wrap up. We're kind of at the 45-minute mark here. So Dr. Lin, Dr. Miccio, I really want to thank you. I think this was a really interesting talk, a lot of different treatments that are out there. And it just highlights the different kinds of pain that we can have and lots of ways to approach that. So thank you, everyone. And thank you for coming to our webinar today. And if we didn't get to your questions, I'm sorry about that. You are welcome to find us online, and you can always come see us at the Spine Center. Okay. Take care, everybody.
Thank you so much.
Thank you.
Thanks.